I'm Dr. Vijay Kumar C Bada. I'm a senior consultant in surgical gastroenterology, minimal access surgery, and HPV surgery, working at Global Hospitals, Hyderabad. Pancreatic cancer has been there since quite some time, and we all know that the 5-year survival rate of pancreatic cancer is dismal in spite of most of the advances. Of late, there have been a lot of changes in the understanding of the pancreatic cancer, like we have gone into the etiology of pancreatic cancer, much advanced technology for the evaluation and also in regards to the treatment. One significant thing I would tell is the early detection of pancreatic cancer. We've got very good CT scans and MRIs which are able to pick up the lesions with their adjacent involvements. And also the operability part, the resectability, there have been a lot of advances with aggressive surgical management. As we all know, that pancreatic cancer, for that matter, any GI cancers, the best intent of cure would be surgical management. So pancreatic cancer with involvement of the adjacent portal vein, supramesenteric vein, and some adjacent organ involvement, earlier they would all be deemed as inoperable or unresectable. But now with the advent of the portal vein resections, reconstructions, even arterial resections and reconstructions, and with studies showing us that there is good benefit with this extended pancreatic resections, the 5-year survival is being improved with acceptable morbidities. So I think these are the changes which we are seeing of late in the pancreatic cancer management. The minimal access surgery has been there for nearly 2 decades, and it was slowly confined to gallbladders, appendix, and other hernias and such things. Pancreatic cancer, and more so Whipple's operation for a pancreatic cancer, has been, all of us know that it's one of the most complex surgeries in GI field. And to approach this to get minimal access benefits were two things. One is whether it could be done laparoscopically. Second thing is, would it affect the oncological outcomes? Would it affect the overall outcome when we compare to open surgery? Because the main thing is that there should be no compromise on the oncological outcome in a pancreatic cancer. So this all started with doing some distal pancreatectomies, some pancreatic cyst managements in laparoscopy. And over the last 4 or 5 years, I can say that laparoscopic surgery for Whipple's in pancreatic cancer has started, and I've done a few of them. So we actually have the results are very impressive. Results have shown that the lymph node yield, to say the oncological outcomes for pancreatic cancer, has been the same when compared to the open surgery, and also the morbidity is much less. So we have all the benefits of laparoscopic surgery with the pancreatic cancer, but it's a very technically demanding procedure. There's a lot of learning curve involved. Very few centers would be able to do this. So it takes time for more people to do laparoscopic Whipples, but definitely laparoscopy for pancreatic cancer is here to stay, and there are good results, and randomized trials are coming up with this comparing with the open surgery. Laparoscopy for any GI malignancy is possible now, be it the esophageal cancer, be it the gastric cancer, the colorectal cancers, or for the HPV cancers. More and more improvement in the technology, more and improvement in the type of the laparoscopic equipment we are having, and the expertise with good centers. All the GI malignancies would be able to be done laparoscopically. The only problem was with the esophagus, where we had a thoracic part to be dealt with. So now we are doing thoracoscopic, laparoscopic combined approach for doing managing the esophageal cancers. Similarly for stomach, even the D2 gastrectomies. Always the problem for some people with laparoscopy has been, is it going to be the same oncological outcome? Be it in terms of tumor-free margins, be it in terms of the amount of lymph node retrievals and the reconstruction. So all these have been shown with level 1 studies that the oncological outcomes are the same for any GI malignancies. For rectal cancers, it's much more advantageous for the patient because we are able to save the sphincters as much with minimal morbidity. So I think laparoscopy for any GI malignancy is possible with the same oncological outcome, with much better advantages of laparoscopy, say minimal morbidity, shorter hospital stay. Cost was an issue quite few years back, saying that laparoscopy would be now exorbitantly very costly, but nowadays that is also not there. It's almost matching with the open surgeries. So I think with all the advantages of a minimal access approach to any GI malignancy can be offered to all the patients. And the most important thing is how the people get into this one, and the learning curve is more important. More and more training would be important in this issue, I feel. Skill does matter, because we sometimes call that as high volume centers. Even for open surgery it is there, and for laparoscopic surgery also, where studies have shown that for, say for example, a colorectal cancer, any center or any surgeon who does around 15 to 20 surgeries per year, that becomes a high volume center. So there the results are much better when compared to a surgeon who's done very few numbers. So the skills are very important. That is why anyone who is doing a basic laparoscopic surgery needs to be trained in advanced laparoscopy, and then he can reach the next level. So doing a gallbladder or appendix in laparoscopy is one thing. Moving on to doing some hernias, fundoplications, splenectomies is the next thing, and then you come on to the malignancies. Because handling GI malignancies by laparoscopy, the care has to be taken that there is no difference when compared to the open approach, specifically with the oncological outcomes. And doing a pancreatic surgery, a Whipple's laparoscopic, is, as we know, in the open only, it's very complex. And the leak rate, the pancreatic leak rate and the bile leak rate are much, reasonable in the open group itself. So to match the same things in laparoscopy, there you have the importance of the skill, the learning curve, and the facilities coming into play. All these days, quite some time, the GI surgery was sort of merged with the general surgery. So most of the general surgeons still do a lot of GI work. But now with the GI surgery becoming a super specialized subject with MCH and DMB available in this, so there's been more focus on GI surgery. So there is good outcome for the patients and the society at large. And within GI surgery, now we are having subspecialization as the HPB surgery, the colorectal surgery, and the minimal access surgery itself is taken off as an offshoot of this one. So with subspecialization coming in, I think GI surgery is going to be more refined with much better outcome. So all this is going to translate into good healthcare benefit to the patients and the society at large, because we all know in all the fields, more specific we do, the much better would be the outcome. So the training programs are getting streamlined now, with the Medical Council and the Government of India putting more efforts into streamlining the subspecializations. I think GI surgery will take off in a much bigger way.